Hi everyone, this is Team 9. My name is Jonathan Maya. I'm a third-year health science major on the pre-medical track. We also have Olats Ariaga, who's a third-year health science major also on the pre-medical track, and Christy Telez, who's a third-year health science major on the pre-occupational therapy track. Today we're going to be discussing the current state of rural and critical access hospitals across America. A critical access hospital, or CAH, is a designation given to eligible rural hospitals by the Centers for Medicare and Medicaid Services, or the CMS. Typically, these are designed to reduce the financial burden on and improve access to healthcare for patients living in remote areas away from most healthcare settings. To be considered a CAH, the hospital must have 25 or fewer inpatient beds available, be located more than 35 miles away from another hospital, and maintain an average length stay of 96 hours or less for acute patients. And, like normal hospitals, also provide 24/7 emergency care. As of July 19th, 2019, there were 1,350 critical access hospitals located throughout the United States. And as you can see by the image shown, that they are dispersed across the country, but heavily concentrated in the Midwest, which makes sense given that those regions probably have the most rural areas in the country. While there are a variety of benefits that come with being a CAH, there are drawbacks as well that are worth discussing. One of these benefits is cost-based reimbursement from Medicare. As of January 1st, 2004, CAHs are eligible for allowable costs plus 1% reimbursement. It is important to note, however, that as of April 1st, 2013, reimbursement is now subject to a 2% reduction due to sequestration, which is a direct product of the Affordable Care Act in 2010. Other benefits of CAHs include flexible staffing and services, as well as educational resources and technical support. Even with these benefits, there are many issues with critical access hospitals when it comes to the quality of care that patients might receive. Recent retrospective analysis indicates that compared with other hospitals, 26.8% were less likely to have intensive care units, cardiac catheterization capabilities, and have extremely basic electronic health records. In addition, patients admitted to CAHs had a higher 30-day risk-adjusted mortality rates for all three conditions that were looked at extensively, which in this case were acute myocardial infarction, congestive heart failure, and pneumonia. Overall, CAHs are crucial because they provide health services for patients who would otherwise not have access to care, but they do tend to have a lower quality of care. Most patients, however, still choose CAHs because it is their only option.
In a rural community, a single hospital may be the only source of care available for a large population. In an effort to satisfy their individuals' demands, specialized services that are crucial in urban hospitals have been implemented, such as the ICU. Critical access hospitals have proven to have the capability of providing care to specialized patients in the presence of appropriate resources and finances. All hospitals, whether urban or rural, have a common goal of optimizing their patients' health outcomes and earning greater revenue sources. However, there is an evident difference in the distribution of resources among hospitals in different geographic areas. Data obtained from 4,800 hospitals providing care to Medicare beneficiaries concluded that critical access hospitals are less likely to provide care that met quality standards in comparison to other hospitals. These hospitals lack the essential personnel, equipment, and protocol to manage patients in critical care upon admission. In rural hospitals, nurses are usually the primary decision makers when treating trauma patients until a physician is available, which is significantly different from the care administered at an urban facility. This better explains why rural communities do not receive the adequate care needed. Recently, hospitals all over America have begun to incorporate electronic health records and technology into patient care. Ongoing research has linked specific IT applications to the reduction of medical errors, improved patient outcomes, and enhanced organizational performance. As this trend is rapidly on the rise, a recent study found that rural hospitals are only using about 30% of patient safety information technology available, compared to the 50% that urban hospitals are utilizing. Some patient safety information technology applications, such as pharmacy-based systems, clinical decision support systems, and outcomes and quality management tools were all more likely to be present in urban hospitals rather than rural critical access ones. This lack of use of information technology is one of the leading factors as to why the quality of patient care is subpar in critical access hospitals.
A survey conducted on 793 critical access hospitals identified that the challenges critical access hospitals face when implementing or trying to implement information technology are financial issues, challenges with workflow and staffing, technical challenges, and security and privacy issues. Financially critical access hospitals had challenges during the implementation of broadband and electronic health record systems. Broadband refers to high-speed internet access that is always on and faster than traditional dial-up access. The monthly prices for high-quality broadband plans can reach up to thousands, which can be expensive since small rural hospitals have more limited access to financial resources compared to other acute care hospitals. Similarly, the implementation of the electronic health record systems posed a financial load in critical access hospitals due to their high costs. The cost of electronic health record systems can range from $15,000 to $70,000 per provider, and that does not include the yearly maintenance cost or the cost to implement personal computers, printers, and scanners. The challenges critical access hospitals faced regarding workflow and staffing were lack of IT personnel, which played an integral role in making sure the system is running effectively, and challenges with clinical staffs and executives' cooperation with health IT adoption and use. All these factors and many more explain why critical access hospitals and rural hospitals might not be implementing IT technology. After the installment of cost-based reimbursement for critical access hospitals, it has allowed these facilities to adjust to the changes in healthcare and meet the needs of their population. With the growing use of telemedicine, tele-intensive care units were gradually implemented into critical access hospitals. A tele-intensive care unit connects a critical care team with patients in distant areas to communicate health information by visual and audio waves. Researchers concluded that this technology significantly reduced mortality rates and decreased the length of stay by about 30% in intensive care units. In collaboration with the use of electronic health records, the available physicians can obtain readily access to patient information in order to provide appropriate care. With the use of telemedicine, rural communities can receive greater quality of care, leading to patient satisfaction and incentives for rural facilities to improve their reputation. Discussion questions. What changes or proposals could you suggest that address the challenges rural and critical access hospitals face? Explain why you chose them. Secondly, as a healthcare provider, what personal and professional qualities would be needed to properly deliver care in a critical access hospital?